Hi, my name is Sugit Jagpal. For those of you that don't know me, this is our first virtual morbidity mortality improvement conference. It is going to be led by Dr. Scott Ventre and Dr. Cherie Tan, the two PGY2s. Scott is going to go on to be one of our chief residents in the 2021-2022 year, and Cherie will be going on to a Heme-Onc fellowship after this. As always, the first half hour will be a case discussion and an analysis of the case, during which interruptions, including using the chat box, are not welcome. And the following 20 to 30 minutes will be an open discussion amongst all of us about things that we think could help with patients such as this one. So I'll turn it over to Dr. Ventre.
Okay, can everyone hear me? Okay. So thank you, Dr. Jagpal. Hi, everyone. I'm Scott Ventre. Cherie and I would like to thank you all for being here today. I know this is not a format we're all used to, but given the circumstances we're working under, hopefully it will still be an enlightening experience for everyone. So does everyone see my screen up in the PowerPoint? Yes, good. Okay. All right, let me see if I can. There we go. So first off, we just want to thank our faculty advisor, Dr. Jagpal, for all she's done in helping us organize this M&M. It certainly wouldn't have been possible without her. And then a big thank you also to the individuals, some of whom you'll hear from later, who have helped shape our knowledge on the topics we'll be talking about today. Lauren Solomon, Vicki Pitson, Miriam Shanzite, Dr. Roger Chang, and Dr. Scott Aronson. So as a reminder, the general purpose of an M&M is to create a safe forum where we can spark a discussion about the events leading up to an adverse patient outcome in order to determine ways to improve patient care in the future. However, as a preface to our presentation, I'll tell you that the case we'll be discussing actually doesn't necessarily demonstrate any particular error in patient care. Rather, this case will be focusing on an unfortunate event we commonly see in the inpatient setting. The discussion thereafter will focus on what we can potentially do to limit these types of events. With that, let's get started with our case. So our patient was a 55-year-old gentleman with a history significant only for poorly controlled diabetes, who presented with fever, cough, and shortness of breath for 10 days, ultimately found to be positive for COVID-19. He had actually presented to the emergency room 5 days prior to the day of admission for the same symptoms, but was able to be discharged from the ED at that time. The rest of his past medical, surgical, and social history are essentially negative or non-contributory. It's the diabetes on metformin. In terms of on admission with his vitals, he was found to be febrile, 102.4, tachycardic to the 120s, and quite hypoxic on room air, requiring early supplementation with both oxygen via non-rebreather as well as pronation attempts. He otherwise was in no acute distress and was mentating well. In terms of his labs, CBC and BMP at the time of admission were within normal limits, but his inflammatory markers, including D-dimer, LDH, ferritin, and CRP, were markedly elevated. Chest X-ray on admission essentially showed an elevated left hemidiaphragm as well as development of diffuse interstitial and airspace opacities, which when compared to the X-ray from his ED visit 5 days prior on the left ear screen are quite increased. So just going through his first day of hospitalization, the patient was admitted early in the morning at around 1 a.m., saturating decently on non-rebreather. He was admitted to cluster level care and started on hydroxychloroquine, as well as ceftriaxone and doxycycline for possible superimposed community-acquired pneumonia. The following afternoon, the day team called the MICU screen, given increasing oxygen requirements and desaturation on non-rebreather. At that time, MICU recommended a trial of high-flow nasal cannula. However, patient continued to desaturate with increased work of breathing, and unfortunately by 6 p.m. anesthesia was called for intubation, and the patient was brought up to the MICU. So with that, we'll start building our timeline here, with hospital day 1 being his diagnosis of COVID-19 and rapid decline leading to intubation. On his second hospital day, the patient remained sedated on the vent, requiring a small amount of norepinephrine, which is a pressor, and the vent was maintained at low tidal volumes with high PEEP, which are protocols we use for presumed developing ARDS. Early in the morning on the following day, roughly 1:30 a.m., which was roughly day 13 of the patient's COVID-19 illness, the patient spiked a fever of 109. He became acutely hypotensive, requiring max doses of Levophed, as well as initiation of vasopressin. The night team placed a cooling catheter, after which he stabilized. Now, this was presumed to be due to cytokine release syndrome, given the elevated inflammatory markers as seen here. You can see in comparison to his emission labs, all of his inflammatory markers spiked dramatically when they were collected during this event at 1:30 a.m. IL-6 level was checked about 12 hours later, and at that time was also found to be mildly elevated, 11.4. It was at this time that a dose of tocilizumab was given, and the patient was started on IV steroids. His anticoagulation was also switched to intermediate dosing of therapeutic Lovenox. The patient was given a sedation holiday later on and was found to be unresponsive with only brainstem reflexes present. Palliative care was thus consulted to discuss goals of care. So we'll add that to our timeline, highlighting what appeared to be cytokine storm, leading to decompensation and subsequent stabilization of hemodynamics thereafter. In the following 2 days, hospital days 4 to 5, the patient remained hemodynamically stable and was able to be weaned off pressors, and his inflammatory markers started to improve as well. However, his mental status continued to decline, now with decreased brainstem reflexes. It was at this point that a workup was initiated for his altered mental status. EEG showed evidence of diffuse dysfunction, often associated with toxic metabolic encephalopathy. And then in discussion with palliative care, family chose to keep patient full code with hopes for eventual neurologic recovery. So at this point in the hospital course, the outcome was looking quite grim for our patient, or at least guarded. However, on hospital days 6 to 8, the patient began to show signs of improvement in his neurologic status, opening eyes to voice, following simple commands, and moving his arms and legs. Nearly all of his metabolic derangements, including his inflammatory markers, began to improve. The patient performed well on pressure support for 2 days, met all criteria for extubation, and was successfully extubated on hospital day 8. His neurostatus remained essentially stable without much improvement over the next 2 days. However, with a CT head unrevealing for a possible cause. Of note, the patient did fail a bedside swallow eval, which triggered a formal evaluation by speech and language pathology, which he unfortunately failed as well. If you read their notes, it looks like it was due to impairments throughout multiple stages of swallowing, leading to the recommendation of strict NPO, strict oral care, and alternate means of nutrition. Thus, an NG tube was placed for tube feeds at that time. Days 11 to 12, his neurologic status remained essentially unchanged, and he was downgraded to a med-surg floor. Given the lack of neurologic improvement, despite improvement in nearly every other aspect throughout his hospital stay, his case was discussed informally with neurology, who basically explained that in the setting of COVID, improvement in encephalopathy can sometimes lag behind. So we can see in this updated timeline, note that since the 3rd day of hospitalization, it's basically been the patient's encephalopathy driving his course. This brings us to hospital day 13. At 10 a.m., it was noted in the chart by the primary team that the patient was no longer responsive to voice, nor was he following commands, which was a change from prior. He was also tachycardic, and where he was previously stable from an oxygenation standpoint on room air, he was now requiring oxygen. Although there was no significant change on chest x-ray, the primary team was concerned that the patient may have aspirated and had now become septic from aspiration pneumonia, thus explaining potentially the worsening encephalopathy. He was thus started on vancomycin and Zosyn. At 1 p.m., same day, he spiked a fever of 100.7, remained tachycardic, and then a little after 4:30 p.m., the patient became acutely hypotensive and hypoxic. A rapid response was called. When the rapid response team arrived, the patient went into PEA arrest. He was coded for 10 minutes, achieved ROSC, and coded again soon thereafter and achieved ROSC, and then was transferred up to the MICU, but unfortunately went into cardiac arrest a 3rd time soon after arrival and was unfortunately unable to be resuscitated, bringing us to the end of our timeline. Now, although family did decline autopsy, given the patient's lingering encephalopathy and dysphagia, coupled with his acute change in hemodynamics, drop in oxygen saturation, and subsequent rapid decline, it's believed that the likely cause of death here was an aspiration event. So as I mentioned before, this is going to be a bit of an untraditional M&M because instead of there being an error in management leading to an adverse event, we're going to instead use the morbidity of this case, the aspiration event, as a springboard to discuss why these events happen. Not to say that something could have been done differently in this case, but rather what can be done in general to minimize the risk in all of our patients moving forward. With that, here's a fishbone RCA, which brings up factors, some of which are specific to our case, and many that are more general. On the left, we see factors related more specifically to our patient who had COVID-19. So in this case, it was actually happening, it was in the earlier weeks of the pandemic here, when we really didn't know as much about the clinical course of the disease, which made predicting outcomes and managing complications like cytokine storm that much more difficult. We were also limiting physical exams at that time, and patients were being kept out of eyesight from the nurses due to doors being closed all the time. Now, the rest of this diagram includes more generalizable factors. The ones we're going to be focusing on are highlighted here. So they're more centered around encephalopathy, more specifically in these patients that are post-extubation, and the difficulties of managing the sequelae of encephalopathy in the hospital, which include aspiration events. So we'll start off by talking about encephalopathy in general and the ways in which the simple nature of our approach to diagnosing it can oftentimes be detrimental to the patient. Encephalopathy is an unfortunately common and in many cases life-limiting condition that befalls our patients. In a prospective study of 500 patients with a Glasgow Coma scale of less than 8, and for those of you who don't know, an under 8 score essentially correlates to severe brain dysfunction. In this case, in the setting of non-traumatic causes, overall, only 10% of these patients made what was deemed a good recovery, while 63% either died or recovered only to the point of being in a persistent vegetative state. In another study, when MICU patients in general were followed, 32% of them were still impaired neuropsychologically at 6 months. So this is something that we really need to take seriously. Encephalopathy, by definition, is a clinical disorder manifesting as global cerebral dysfunction without any identifiable structural brain disease. And the etiologies are numerous and could even overlap, including things like infection, inflammation, metabolic derangements, neurologic syndromes, poor nutrition, hypoxia, ischemia, and more. The treatment, of course, is based on the etiology. Because of this, encephalopathy can often require a pretty substantial workup. So just to bring it back to our case for a moment, let's go through some of the workup that our patient underwent. So for infection and inflammation, we note that when the patient was first noted to be encephalopathic after his cytokine storm was treated, he was no longer febrile, he had ultimately negative repeat cultures, and his inflammatory markers were downtrending, but were rather high initially, admittedly, so perhaps we thought that was the triggering event, which makes sense. Otherwise, however, his renal function, hepatic function, electrolytes were all normalizing. Both his CT head was negative. His EEG didn't show any seizure activity specifically. No evidence of malnourishment on labs, and he was being fed. And then during what appeared to be the peak of his encephalopathy, he was saturating well and appeared well perfused, as shown by his decreasing pressor requirements. And no new medications were introduced in the interim, or at least none that are, I guess, typically implicated in encephalopathy. So what I want to draw your attention to was that maybe we had the right answer from the beginning, but the workup needed to be done. And it was a lot of workup. And most importantly, this workup panned across multiple hospital days during the patient's hospitalization. So this brings us to our focus to a concept known as diagnostic process evolution. In general, when we work to diagnose our patients, there are 3 possible outcomes. 1, we diagnose and successfully treat the patient. 2, the disease gets better without any intervention. Or 3, the disease gets worse and the patient suffers because of it while we're in the process of diagnosing or attempting to treat them. It's that final outcome for which this process becomes important. The concept is that the moment a disease process begins in our patient, the clock starts. The disease potentially can have effects before we can even identify it. However, when the disease is identified as being present, the clock is still running. The disease may still be affecting our patients while we're working up the disease, trying to decide whether or not we're going to treat it, etc. And all this information gathering and decision making takes time. So here's just a kind of a graphical representation of this, and we're focusing on the bottom center part of the image, where after it becomes evident the patient has a condition, which again can take time, we then have to deal with the complexities of the disease, the inherent delays in our healthcare systems, and the fluctuating course of the disease, all of which can cause delays in diagnosis, and in doing so keeps the window open for patients to suffer an adverse event because of that disease. And so this is the concept. While we're diagnosing patients, time still passes. This leads us to the question, how can we mitigate the risks of these quote unquote opportunistic adverse events prior to when we reach a diagnosis and complete treatment for these patients? And that's our challenge. So let's talk about diagnostic process evolution and how it relates to encephalopathy. Specifically, let's look back at the workup for our patients. Blood cultures can take 5 days to result. EEGs, CT scans, all of these take time. Furthermore, our patient had a very fluctuating course. He got better, he got worse, he got better again, which all this can make us feel more secure that maybe we don't have to do any further workup and we can just, watch and wait and rely on what we think was the diagnosis to begin with. But the point is, during that time, the patient was still vulnerable. And vulnerable to what? What are these opportunistic adverse events that can occur as we go through our diagnostic process in the setting of encephalopathy? Well, the opportunistic adverse events of encephalopathy are numerous. Over time, patients can develop malnutrition, increased fall risk, deep tissue injuries, all as a manifestation of failure to thrive. They're given drugs to combat the symptoms of their encephalopathy, as well as attempts at treating the underlying problem, which leads to polypharmacy and its sequelae. They generally have increased length of stay, increasing the risk of hospital-acquired infections. And all of this leads to an increased burden, financially, physically, psychologically, on patients and their caregivers. However, what we're going to focus on for the remainder of our PowerPoint here is the adverse event that we see all too often, which we believe our patient suffered, which was an aspiration event. And with that, I'm going to hand it off to Cherie.
Thanks, Scott. Can everybody hear me? Okay, so now we'll switch gears a little bit and talk about aspiration as one of the morbidities associated with ongoing encephalopathy and one that resulted in our patient's mortality. I'm going to talk a little bit about post-extubation dysphagia, but the main bulk of it is trying to prevent aspiration events. So there's a significant economic and survival burden for patients with dysphagia. In a study with 88 million inpatient adults, 2.7 million had dysphagia. And they found that those with dysphagia required 3.8 additional hospital days, which translated to a 43% longer length of stay compared to those without dysphagia. As a result, the cost for these patients was about 33% higher. Another study evaluated 550 patients with aspiration pneumonia. 17.3% of patients died during the same hospitalization, with 24% readmitted for repeat aspiration events. Briefly, before going on, I just want to review the pathophysiology of the swallowing mechanism. There are 4 phases in total, 2 of which are voluntary and the other 2 which are involuntary. The oral preparatory phase, seen in figure 1, is a voluntary phase where the bolus is formed. The oral transit phase is when the bolus is pushed backwards towards the hard palate, seen in number 2. The pharyngeal phase is an involuntary phase where the swallowing reflex is activated when the food bolus is in contact with the palatoglossal arch. This leads to a complex coordination to ensure airway closure, involving vocal cord adduction, ventricular fold adduction, and contact of the arytenoid cartilage with the epiglottis. At the same time, active laryngeal elevation indirectly opens the upper esophageal sphincter, allowing the food bolus to pass. It is at this stage where aspiration can occur if there is a disruption in the coordination. Lastly, in the esophageal phase, the bolus is propelled by peristalsis into the stomach. Post-extubation dysphagia is an example of disruption in the swallowing mechanism and one that we see frequently in the ICU. Up to 60% of patients have post-extubation dysphagia, with 50% of these patients aspirating. A study showed that 32% of ARDS survivors have persistent dysphagia at discharge, with 77% recovering less than 6 months at follow-up. There are multiple mechanisms that contribute to the development of post-extubation dysphagia. The most obvious are direct trauma by the ET tube and muscular weakness from deconditioning. Other mechanisms include diminished laryngeal sensory function, resulting in poorly responsive swallowing reflex, central nervous system deficits such as encephalopathy or stroke, reflux, and dysynchronous breathing and swallowing that affects the appropriate coordination of airway closure. As a result, patients who exhibit post-extubation dysphagia undergo a swallow eval before starting oral feeding, which can be modified depending on the degree of dysphagia. For those with severe dysphagia, like our patient, it is recommended to stay NPO to reduce the risk of aspiration. True aspiration is thought to originate from bacteria in the oral cavity or nasopharynx, which technically can occur in strict NPO patients. However, the data is limited for strict NPO dysphagia patients. The data that we found was mostly for pre-op patients who were NPO after midnight, for which these studies don't really exhibit an increase in aspiration risk. Studies have shown, however, that for patients with an NG2 with NG tube feeds, the incidence of aspiration pneumonia and death was 31% compared to 10% in orally fed patients. The presence of an NG tube results in the loss of anatomical integrity of the esophageal sphincters, more frequent relaxation of the lower esophageal sphincter, allowing for reflux, as well as desensitization of the swallowing reflex. For our patient, much like those reflected in these studies, he exhibited post-extubation dysphagia, which resulted in failing his swallow eval multiple times. In order to obtain nutrition, an NG tube was placed for tube feeds, which seems to have predisposed him to a potential aspiration event despite technically being NPO. There are multiple ways we can intervene to prevent aspiration events. One way is to reduce encephalopathy by assessing bowel bladder function, aggressive mobilization, pain assessments, day-night orientation. As physicians, we can continue to check for electrolyte abnormalities and reviewing medications to avoid polypharmacy. We recognize that there are difficulties to implementing this in the time of COVID, given the need for PPE conservation and reducing exposure to staff. But ideally, we'd also like to have family members at bedside to assist with reorientation as well. Our nursing staff are actively implementing aspiration precautions for our patients. When we put in an aspiration precautions order, these are just a few of the interventions that are taking place. Patients are given a 30-minute rest period before eating. They're sat upright. The rate and size of bites, as well as the consistency of the food, are adjusted, as well as the food placement are all considerations. Patients are also given routine oral care as well. For patients with tube feeds, the head of the bed should be kept elevated to at least 30 degrees, but for those with delayed gastric emptying, we can also consider a prokinetic agent or post-pyloric tube feed placement. A 2019 study investigated the effects of swallowing and oral care intervention on time to resume oral intake and salivary flow after extubation. Pictured here on your left is an outline of the intervention for those with post-extubation dysphagia, which included toothbrushing, salivary gland massage, range of motion exercises for the mouth, and patient education. They showed that those who participated in the swallowing and oral care intervention were significantly more likely to resume total oral intake. Keep in mind that in the study, patients who were unable to follow instructions were excluded and thus needed a certain level of cognitive function to participate. There are also a few studies that research the effect of multidisciplinary team approach in order to reduce aspiration. One study developed an aspiration precaution protocol for nurses, speech therapists, dietitians, and food and nutrition services. Their number of aspiration events decreased from 162 to 154, and mortality associated with aspiration complications were reduced by 17.9%. While these numbers were not significant, it did reflect an overall decline with use of the protocol. Another study developed a multidisciplinary swallowing team, which included physicians, dentists, nurses, PT, OT, speech, dietitians, dental hygienists, and pharmacists. And they investigated pneumonia events in acute stroke patients with dysphagia before and after the implementation of a swallowing team. And they found that the swallowing team approach significantly reduced the risk of pneumonia by 61%. So while research is limited and ongoing, these studies have shown promise in reducing aspiration events in patients with dysphagia. So now we would like to invite thoughts from our specialists before opening up the discussion to questions from the audience. Today we have Lauren Solomon, one of our senior speech language pathologists, who has been practicing for 8 years now, 6.5 at Robert Wood, with special interest in dysphagia related to multiple comorbidities. We have Dr. Scott Aronson, who's also with us today. He's a gastroenterologist in our community with the Digestive Disease Center of New Jersey. He is a Robert Wood residency alumni who completed his fellowship at Mayo in 2009. Before returning to this area, he spent 3 years as a faculty member at Long Island Jewish Medical Center, where he participated as a founding faculty member in the Hofstra North Shore LIJ School of Medicine. He has been with the Digestive Disease Center of New Jersey since 2012. And lastly, we have Miriam Schonzeit, one of our senior occupational therapists, who is with us as well. She has been practicing occupational therapy for 11 years at Robert Wood with an interest in working with neuro and pediatric patients. Thank you for joining us today. So what are your thoughts regarding the case from your specialty perspectives?
Thank you so much for allowing me to participate. So I think as both you and Scott were saying in terms of aspiration, that it can occur really aside from being eating and drinking. So a patient who's NPO. And this was actually further proven in a study that looked at 189 elderly subjects who were part of outpatient settings, acute care settings, and nursing homes. And they followed these patients for 4 years to see if they developed aspiration pneumonia. The patients were looked at using a variety of assessments. They included swallowing function, their feeding status, their functional status, medical status, and also their oral and dental status. And they found that there were significant factors that were associated with pneumonia. These included dependency for feeding, so being dependent on somebody else, being dependent for oral care, the number of decayed teeth, having more than one medical diagnosis, the number of medications. The more medications, the more likely to develop an aspiration pneumonia, smoking or smoking history. And so, you know, for our patient in this case, he was certainly dependent on others for oral care and was utilizing tube feeding, which you had discussed. And this, you know, this article also showed that dysphagia was an important risk factor for aspiration pneumonia, but it was generally not sufficient to cause pneumonia unless these other risk factors were present. So I think as a collectively, you know, that's important to think about when we have these patients who are NPO, you know, what else can we do to mitigate the effects to possibly develop an aspiration related event?
Is it my turn to jump in? Okay. So from a GI standpoint, you know, we're often involved in patients with dysphagia, often asked to intervene, usually later on in this patient's course, you know, when there either is a need to investigate causes or consider placement of feeding tube and enteral nutrition. So as I said, this patient, you know, with encephalopathy is fairly early in the course to when we would normally be involved, but some of the thoughts are effects of esophageal motility, you know, was mentioned of that as an involuntary part of swallowing. You know, this patient coming out of the ICU with sedation, being encephalopathic, there is some decreased esophageal motility, which will reduce his ability to clear substance from the upper airway. Question of the gastric motility that you know, is another one to consider, especially with more reflux if he's lying supine in bed and not able to control his secretions properly. There was some mention of whether to use metoclopramide or erythromycin. You know, of course, metoclopramide has many side effects, so be careful with in patients like this. And erythromycin, there's very rapid tachyphylaxis. So typically after a few days of using that to increase motility, won't necessarily be very helpful, but at least to get things started, it would be. Part of why Dr. Jagpal asked me to be involved was because when I was in my fellowship training, we had a service that was multidisciplinary, involved speech pathologists, dietitians, gastroenterologists, endocrinologists, who would basically help to make assessments of feeding tube placement, or had to give the go-ahead before scheduling PEG placements. And so often we would look at those patients from and think about all the risks. One of the key points that we always emphasized to our teams was feeding tubes, particularly PEG feeding tubes, or PEGs even, post-pyloric tubes, don't necessarily decrease aspiration risk. They're simply means of providing nutrition. The fact that NG tubes can decrease the integrity of the upper and lower esophageal sphincters, so there is some small advantage to placing a tube in the stomach or distally. But overall, though, the true aspiration risk in these patients has not been shown to improve by placing the feeding tube. It's purely an alternative means of providing nutrition to the gut. So I guess that's the kind of my main key points I was going to address.
Thank you. I guess it's my turn now to jump in. This is Miriam. I'm sorry my video doesn't seem to be working, but I'm from the Occupational Therapy Department. Does everyone hear me?
Yes, you
okay,
are.
great. Great, thank you. So OTs contribute often in a couple of ways to the management of encephalopathic patients. One way that both occupational and physical therapists contribute to encephalopathic patient care is by working on strengthening and mobility. By working on patients' ability to sit up and get out of bed, we can affect their core control and their head control, which will help facilitate safe eating and swallowing. The other things that OTs in particular address are the sensory aspect of things. So we work on patients' ability to sense proprioceptive input and tactile input, and we focus quite a bit on vision. And all of those things are kind of part of that big, picture of people being able to, of patients being able to know how much food is on their spoon, where their food is on their plate, and make some of those judgment calls that are necessary for safe self-feeding and safe swallowing. The other area that OTs focus a lot on in the acute care setting, and which really plays in a lot with the management of encephalopathic patients, is working on cognition. And with our severely encephalopathic patients, like the patient that we're discussing in the earlier part of his course, we will work on things like arousal and the patient being awake, which would carry over into the patient being awake enough to eat and awake enough to swallow safely. We'd work on kind of that night and day orientation so that hopefully they are awake and alert for meals. And we'd work on patients' alertness and attention to their surroundings. As the patient progresses, though, we'd work on more complex cognitive skills, which also tend to tie into feeding. So things like sequencing and executive function and safety awareness. So which would tie into knowing how much they're about to eat, being aware that they even have swallowing recommendations that are posted by speech, and potentially at more advanced stages, being able to self-monitor and see if they're following those directions. As patients progress and become more cognitively aware and become closer to intact, we focus on things like more advanced executive function and sequencing, and we may use tools such as the MOCA, the Montreal Cognitive Assessment, or the SLUMS, the St. Louis University Mental Status, I believe, which assess many different areas of cognition and can kind of help us fine tune and get a better idea of where to focus our efforts. And many areas of cognition that are addressed by these tests and are addressed by our treatment sessions can help patients become more safe with their eating and with their swallowing.
So thank you to everyone who spoke and all of those in the audience. We now have time for what we usually consider our open discussion, where we pass around the microphone. So we can do that virtually. You can use the chat function to type in any thoughts or comments or questions for any of us, for any of our panelists, or you can unmute yourself and we can start a conversation. So I think that's Dr. Willett. She's suggesting that we could do virtual autopsies post-mortality in COVID patients to look for causes beyond COVID. And this is something I believe that our pathologists have also, I think the pathology community is talking about, that all of the deaths being documented as due to a viral pneumonia, that's actually not the most proximate cause of death, it's complications thereof. And could there be something mitigatable in what those complications are? So that conversation I know is ongoing. I don't know where Dr. Fife is in terms of where we are at our institution. From a critical care standpoint, this patient's death, if we were to do his death certificate, we would say aspiration pneumonia secondary to an encephalopathy. And then we would have to say secondary to, we would have to probably decide if we were going to commit to it being from COVID-19 or toxic metabolic from multiple factors, given that we didn't know. Do you want to take that one? So there's a question if the risk of aspiration is lower with post-pyloric feeding. And what are the thoughts on that?
There haven't been, at least that I've seen, very good studies comparing gastrostomy or post-pyloric duodenostomy or jejunostomy rates. Presumably, yeah, there'll be less retained material in the stomach, but a lot of the aspiration is not reflux mediated, it's more so oral pharyngeal mediated.
And just to kind of tag along to Dr. Aronson, you know, but just by feeding past the gut, there's still secretions within the oral cavity. And if you're not managing your secretions well, or your secretions are ridden with bacteria, the aspiration of the bacteria alone can result in an aspiration-related infection, having nothing to do with how the patient was eating or if receiving their nutrition.
Are people able to unmute themselves, or is there a setting that I'm supposed to pick that's supposed to allow you to do that? Okay. If anybody knows, I'm not sure if I have on a setting on this where I can, so there's a question about other preventative techniques for aspiration, whether there's medications that we can use perhaps to dry out secretions. Are those helpful or not?
So I think it's still a little unclear on how specifically this patient aspirated because there was no autopsy. But certainly as a facility, we can be more diligent about our oral care in trying to keep their mouths rid of as much bacteria as possible so that if they are having difficulties with secretions, they are aspirating without including bacteria into that. You know, for this patient in particular, because of his mental status being so poor, he was not a candidate to participate in any instrumental testing to really assess his swallow function to know whether or not he had a true weakness, which would be a potential barrier if we're thinking about any exercise regimen for him.
It's Susan Barkoff. I just wanted to comment that this patient's COVID presentation or his initial crash requiring the ICU transfer was not typical of any of the other COVID patients that we've seen. I mean, we haven't seen other people with temps of 109. So I wonder if his encephalopathy, you know, wasn't typical completely of COVID and may have been appropriate to flag for more concern than the average patient. And the other thing I wanted to just mention is that I recall many instances when we were doing daily COVID rounds where people would comment on the fact that the patient had altered mental status and that neurology at the time had a sort of general policy of saying, well, it's probably COVID and call us back if he's not better within a week.
This is Roger Chang. I'm one of the neurologists. I'll comment on that a little bit. So it's a little bit unclear as to how exactly COVID may cause encephalopathy, but it's been seen. So it's just out of experience from a lot of the ICU patients that we've been consulted on. There's no other real explanation. I mean, you can sort of say that this is sort of just a very severe kind of critical illness type of toxic metabolic situation, but it does seem that they, like several patients do have like a very kind of severe encephalopathic picture. The original SARS virus did have some predilection for the brainstem, so there definitely have been reports of like some like viral infection basically of the brainstem, which can cause coma, swallowing difficulties, encephalopathy, but just any sort of severe viral illness sometimes just results in this encephalopathic picture. And I think like the overall point of this though is that there's not really anything you can do besides supportive care for this specific encephalopathy. I mean, you can't really, it's like having a viral meningitis that's not HSV, you kind of support, but there's not any kind of specific treatment. You can treat the symptoms. So if there's like a lot of agitated delirium or something, I mean, you can use, quetiapine, things like that. But otherwise, it's really just supportive. Like you do the other things that you do for anyone in a critical care setting, trying to normalize day-night cycles, trying to consolidate care to give like uninterrupted rest periods. But specific to that, I mean, it's kind of, by the time you're saying it's like a toxic metabolic encephalopathy, it's kind of just like a vague diagnosis. Like nobody really knows what goes into it. It's kind of just a syndrome that you see, and there's unfortunately not really anything specific that you can treat it, even if it's established that this is due to COVID.
No, I just want to be clear. I'm not criticizing in any way that response, because I agree with you that a lot of times there's nothing specific that you can do. I'm absolutely not criticizing it, and especially in a situation in which the patient load is so overwhelming, that I kept saying I thought that was totally an appropriate response to say, really, we know that this happens and we know that there's nothing more specific to be done in the workup and all that kind of stuff. I just think that in this particular case, I just wanted to point out that this wasn't a totally typical encephalopathy in COVID, just because that fever of 109 is so far out there from what we were seeing.
So,
maybe some ways.
Yeah, I mean, I don't, I actually don't know, like, regarding like the fever of 109, it could just be, I mean, I really don't know. I think like certainly if you're that febrile, like it will make the encephalopathy worse. But this could just be along the lines of the same overall, just like the hyperimmune response that you see sometimes. So I think it's maybe more in line with that, like that type of response. Like why do they get this, this delayed ARDS picture? So I don't know that there's anything specifically, aside from like, yeah, really, really high fevers are going to worsen any sort of mental status. I don't know that there would be anything pointing towards like a specifically worse like neurological cause to create fevers of I mean, they're unusual, obviously. You just like, you don't get that febrile, but I don't know that it points to anything specifically neurological.
Lauren, there were questions about increased bacterial growth if we try to minimize secretions, as well as a question about time course for speech interventions to help improve coordination.
So I think for this case, because of his mental status being so depressed, supportive care in terms of oral hygiene is the best thing that could be done, which needs to be implemented multiple times per day, and would be carried out by nursing assistants throughout the day. There's no, in terms of speech therapy, aside from follow-up assessments as the patient's mental status improves, there's no exercise or treatment, so to speak, aside from the supportive care that the speech pathologist can provide in the patient's state the way that he was. The mental status was a huge barrier for that.
Thank you. There's also a question, maybe Dr. Neubauer or Dr. Sundaram can answer, that's asking about hypoxia being a acute contributor to the encephalopathy.
I don't think Dr. Neubauer is on there unless.
Yeah, I am. But go ahead, Sundar. It took me a while to find the mute.
Same here. You want to go ahead?
Well, I think certainly the hypoxia could be causing, I mean, certainly he's very severe, although I think I remember from the presentation that you were able to oxygenate him fairly well on throughout the course of this. So I'm not sure, I mean, it can be a contributing factor, probably makes it worse, but I'm not sure that it seems to me you were able to oxygenate this patient fairly well. If you can't oxygenate them, I think it would be a significant factor. So do you want to add anything to that?
Yeah, I completely agree, Judy. And the thing that's interesting, and I mentioned this in a previous presentation too, and I think Susan will agree with me, that a lot of these patients, at least the ones we saw with encephalopathy related to COVID, so it's a separate issue if we're talking about COVID encephalopathy, is that it seems like it may be independent of the hypoxia. Because we had a lot of elderly people who were not very hypoxic, who were requiring very little amounts of oxygen, who seemed to have significant encephalopathy. Now, whether that has to do with cerebral perfusion and effects on the brain, blood flow, and things like that, that's a whole conversation we could have. But so two things. One, I think the temperature of 109 that did him in had clear effects on his, the severe hyperpyrexia led to the encephalopathy. I don't know if he completely recovered from that at all. The acute encephalopathy that he suffered from post-aspiration, hard to say whether he had, I don't know if people witnessed the aspiration event, whether there was a period of PEA arrest, something happened that led to significant anoxia again. It's unclear, but clearly there was added hypoxia subsequent to that change in mental status. Oh.
Yeah, I agree, Sundar, about the disconnect between the hypoxia and the encephalopathy in a lot of patients. I also thought it was a bit striking in the presentation that, how quickly this patient ended up recovering enough to get out of the ICU after having such significant an inflammatory response, that it doesn't seem like most of our patients with that degree of lung involvement and who crash that badly come out of the ICU that quickly.
I'm not sure what the answer to this is. Again, we're trying to make get an idea of the time course of such an illness. And as we know, in all these COVID patients, there seems to be different patterns, different phenotypes. And he did get tocilizumab, and whether, that it suppressed the inflammatory response and therefore helped prevent further lung injury. And so he recovered, but his encephalopathy persisted because he had anoxic damage to the brain from the hyperpyrexia, or the hyperpyrexia led to significant damage to the brain. Probably, I think, the inciting event was clearly the 109 temperature, initial inciting event. He did recover some, but I think any small event subsequent to that is going to significantly affect the mental status, as we know.
Any last questions? Any parting advice?
Yeah.
Or
Lou Amorosa, can you hear me?
yes.
Thank you for the presentation. This is something I don't think of much. But when I did this type of medicine, anecdotally, I was impressed that innate French and these difficult situations may have led to less trouble with the esophagus than our conventional NG tubes. Is there any data that using a pediatric feeding tube in these situations might limit, reflux or this type of complication? The size of the feeding tube?
I haven't seen any specific data. I know a lot of times we're using Daub-off tubes. Certainly helps improve sinus clearance. As we know, larger NG tubes in the nostrils. I remember as a resident always being told increased risk of sinusitis and complications in that along those lines. I imagine, again, I haven't seen good data or need to go track down some data on it, but the caliber of the tube will still compromise the sphincters and still allow reflux as a conduit. But the reality is most of the patients that end up having aspiration events don't have lungs full of tube feed. They end up with oral pathogens in the lungs.
Okay, I want to make a comment. In general, I've not been that bedside with these patients, and I really congratulate and admire all you guys who've done that. But as a bystander reading about what's going on, I think the use of steroids is probably helpful, as we do at our center for this cytokine storm. But my take is that maybe they're being used too late. This guy was diabetic, which is a big risk factor. Scott, you didn't tell us what his BMI is. Was he overweight? Chest x-rays didn't look that bad, but if he had a big BMI, he's got a lot of fat. And adipose people are a big risk factor. We think that the ACE2 receptor is expressed in adiposity. And incidentally, for Roger, I think there's evidence that ACE2 is expressed in the brain. So the virus can get into the brain, and it gets into the autonomic nervous system where ACE2 is expressed in the sympathetic control mechanism. But what I'm getting at is if the guy was obese, he could have had a lot of ACE2 around in his adiposity. So he was high risk, and he was high risk of a cytokine storm. So instead of his temperature going to 109, and this is for Dr. Jadpal, is there any thought of giving him a lower dose of steroids prophylactically? In other words, you stereotype the guy, he's diabetic, he's overweight, he's coming in now after being in the emergency room 5 days ago, he's getting worse. He's a guy who seems to me who's heading for trouble. Give him steroids prophylactically, not in a dose of 4 milligrams of dexamethasone every 6 hours, but a more reasonable dose that might attenuate a cytochrome storm. Secondly, I think the literature says, well, you're going to knock out his immune function. Well, this virus, it seems to me, is doing a pretty good job of knocking out immune function before there's steroids. So what's the thought about giving steroids early? Is there any thought going on in that? Giving it like in a prophylactic way for high-risk patients?
So this patient's BMI was high. I don't know offhand the exact number, but it was high. In terms of steroids, we have used shorter courses earlier in disease course. We have been doing that, and this particular patient did get steroids as well as tocilizumab, all within 48 hours of each other.
And I just want to point out that when you talk about early, none of our patients that we have hospitalized are really early, because we're not admitting people early in COVID. We're only admitting those people who are already getting into problems. So early isn't really early.
Right. So from a public health standpoint, the unmonitored self-isolation that was requested for this first wave will likely not happen in the second, hopefully. There will be more smarter devices in people's homes if we are asking them to stay home so we can catch hypoxia and other deterioration earlier. Okay, I'm going to close out unless there are any lingering thoughts. We're at 1 o'clock. Secretion, aspiration. Yes, I think that, Lauren, you would agree with that. There's a comment saying that this patient had aspiration of secretions, particularly after extubation, and this was a key factor, and it was unlikely that it was a single event that led to the aspiration.
Yeah, so, after we extubate somebody, and if they are having any oral pharyngeal dysphagia or depressed mental status, that would make them have some more trouble managing their secretions. It's usually the recurrent cumulative effect of repeated aspiration of those bacteria-ridden secretions that will likely then lead to the aspiration infection. Not typically just a single event, I think is what the point there is made. And I agree with that.
And your mitigation would be good oral hygiene multiple times a day.
Yeah, absolutely. I think that's the biggest thing that we can kind of drive home, is that keeping up with their oral care, particularly in these NPO patients who are at high risk to aspirate, would be a great place for us to kind of start.
Thank you. Thank you to Dr. Ventre and Dr. Tan and all of our panelists. Thank you everyone who participated in our discussion for our first ever virtual M&M. I'm going to just close by saying that the deadline to register to vote in New Jersey is Tuesday. Thank you, everybody.
Thank you.
Thank you.